I'm good. How are you?
Thank you very much. Everything is okay. So, today we have a very important lecture. This lecture is Clinical Pharmacology of Antibacterial Drugs. I believe we don't even need to discuss the importance of this topic in the era of coronavirus pandemic, and of course, nearest years will be related with changes of antibacterial world and in changes in bacterial world, and obviously the wide use of antibiotics during last years will cause serious changes of microflora, and of course it will change the structure of microbial representatives in different infections. So today my aim is to explain you main principles of antibacterial drugs use, to show you advantages and disadvantages, maybe some benefits from specific antibacterial drugs classes use, and also to show you the algorithm of antibacterial drug choice. At first, let's take a look at classifications of antibacterial drugs. We need to say that these classifications are different, and we will discuss only the most frequent. So first classification of antibacterial agents is well known. This is a classification in accordance to the spectrum of action. Yes, so officially drugs are divided into so-called broad spectrum antibiotics, narrow spectrum antibiotics, and with a specific spectrum acting on aerobic or maybe anaerobic flora, acting on so-called atypical parasites. Sometimes the understanding of broad spectrum and the understanding of this term broad spectrum, especially in young doctors, is not very correct. Actually, sometimes young doctors assume that broad spectrum is a spectrum which covers everything. And they assume that broad spectrum antibiotic actually can be used to treat any infection, while the so-called narrow spectrum coverage gives you the coverage only of specific strains of bacteria. This is not correct, because actually the presence of broad spectrum means they influence on both gram-positive and gram-negative flora, while narrow spectrum means they influence only on either gram-positive or gram-negative. So the key word is potential influence on spectrums, but it doesn't mean that all of these spectrums are totally covered. Yes, so even the use of broad spectrum antibiotic doesn't give you 100% of coverage. Yes, dozens and thousands of bacterial strains from both gram-positive and gram-negative flora will not be covered by the use of broad spectrum antibiotics. Why is it so important? Because sometimes unexperienced doctors use broad spectrum antibiotics when they don't have the result of microbiological tests, and they use them as insurance to be 100% effective in case when the flora is unknown. But we need to know that even the use of broad spectrum will not give you this 100% of insurance. Of course, your chances to be effective are higher, because some representatives of gram-positive and some representatives of gram-negative are covered, but it doesn't mean 100% of coverage. Do not forget, please, about that when you start to work. Second classification of antibacterial drugs is in accordance to their origin. They can be natural, yes, natural, which are produced by flora in the nature. Semi-synthetic drugs mean that these drugs were synthesized by flora previously, but today medical science has modified these molecules, and we received so-called semi-synthetic antibiotics. And so-called synthetic antibiotics are molecules which are initially not natural, never were natural, and actually they were manufactured by industry. Usually these synthetic antibiotics are maybe even more effective. They have more broad spectrum action, but you should know that usually the frequency of side effects is significantly higher too. Next classification, and for us maybe this is the most frequent classification, is classifications in accordance to the mode of action. So everybody knows that antibiotics can be divided into bactericidal, yes, and bacteriostatic. Everybody knows that bactericidal action means to kill bacterial strains. Yes, take a look at these pictures, killed bacterial strains. Yes, while bacteriostatic antibiotics are drugs which cannot kill bacterial cells, but they can prevent the growth and reproduction of bacterial bodies. Yes, so look at this. They are survived, but they unable to do something. Yes, the most frequent and the most important representatives of bactericidal antibiotics are beta-lactam antibiotics. Yes, penicillin, cephalosporins, etc., which are widely used in daily practice. The most frequent example of bacteriostatic antibiotics are actually macrolides. Erythromycin is present in this list, and tetracyclines. What is how to make the choice bactericidal and bacteriostatic antibiotics. During our classes, our students usually answer is better bactericidal antibiotics because they, how to say, can directly kill bacterial strains. Yes, and we don't need to wait for the action of bacteriostatic antibiotic because bacteriostatic antibiotics cannot kill; they just stop. Um, Frankly speaking, to understand this question better, we need to understand the difference in mechanisms of both bactericidal and bacteriostatic action. Bactericidal antibiotic, killing antibiotic, usually has two main targets of action. First target of action is actually cell membrane. Yes, and classical example is the use of beta-lactams. All beta-lactam antibiotics have this action on cell membrane, and you know this action. Yes, the prevention of peptidoglycan synthesis makes the life of bacterial cell impossible, and the cell is destroyed. Yes, another kind of action is inhibition of cytoplasmic membrane. Please pay attention. Cell wall and cell membrane are different structures. Yes, cell wall can be either peptidoglycan or lipopolysaccharide, while cell membrane actually contains phospholipids. This is usual structure, and humans' cell membranes also contain phospholipids. So both of these mechanisms destroys cell structure and make life of bacterial cell impossible. Uh, what about bacteriostatic antibiotics? The action of bacteriostatic antibiotics can be related with protein synthesis inhibition. Protein synthesis inhibition has a place on ribosomes. And actually, you can see that different kinds of antibiotics have different action on subunits of ribosomes. The most frequent are drugs acting on 50 subunit of my ribosomes, such as macrolides. Yes, but smaller subunits of the ribosomes are affected by aminoglycosides. Yes, we also need to know that some drugs with bacteriostatic action can inhibit the synthesis of folic acid. Folic acid is needed for growth and reproduction of bacterial cell. On these mechanisms, such as sulfonamides, trimethoprim, can also prevent the growth and the reproduction of bacterial cells. So let's conclude. Main mechanisms of bactericidal action are action on cellular wall or cell membrane, while main mechanisms of bacteriostatic action are inhibition of protein synthesis or inhibition of folic acid synthesis. Intermediate position we have for drugs with, if you wish, double mechanism of action. So inhibition of nucleic acid synthesis. In the most of books, this action is described as bacteriostatic action. But we need to know that in therapeutic concentration, these drugs make the life of bacterial cell impossible too. So classical example from these representatives is a class of quinolones and actually fluoroquinolones. In therapeutic concentrations, they give bacteriostatic action, and it is described in the literature as bacteriostatic action. But this bacteriostatic action is related with nucleic acid synthesis. Why is it so important? And actually, you can ask me, yes, how to make the choice of drugs being based on their mechanism of action. We need to understand that drugs with a bactericidal action usually relate their action with the outer structures of cell, such as cell wall and cell membrane. Yes, so being based on that, we can say that they are acting from outside of cell. While drugs with bacteriostatic action, yes, such as acting on protein synthesis, subunits of ribosomes, such as drugs acting on nucleic acid synthesis or folic acid synthesis, they act from inside. Why is it so important? Let's take a look on that from the position of safety. We need to know that classical drugs with bactericidal action, such as beta-lactams, at first, they have an action from outside of bacterial cell, and more important, they cannot diffuse into cells. So this is very important. So they don't have any ability to diffuse through cell membrane. Cell membrane means phospholipids bilayer, yes, in humans. While bacteriostatic antibiotics have a direction inside of bacterial cell, so obviously they should diffuse through cell wall and cell membrane to activate the mechanism of action. And this is very important assumption and conclusion, that bacteriostatic antibiotics act from inside and they can diffuse through cell wall and cell membrane. Why is it so important? Actually, because the introduction into cell is possible not only for bacterial cells, but for human own cells too. This antibiotic has an ability to diffuse through phospholipids. It can diffuse through phospholipids of human cellular membranes. So it means that drugs with classical bacteriostatic mechanisms of action can act on inner intracellular structures of human cell. Let's translate. It means potential side effects occurrence. And if you recall main side effects which are well known for antibiotics, such as nephrotoxicity, hepatotoxicity, hematotoxicity, orthotoxicity, chondrotoxicity, fetotoxicity, usually these side effects are related with bacteriostatic drugs, such as macrolides, such as aminoglycosides, such as fluoroquinolones with this double mechanism of action. And from another side, drugs with classical bactericidal action, such as beta-lactams, are tolerated very well. Yes, we know that sometimes they can cause allergic reactions. Yes, they can cause, of course, GIT disorders such as dysbiosis. But if the side effects are absent, usually they are tolerated very well. So this is very important conclusion, which is based on their mechanisms of action. The use of bactericidal antibiotic usually is safer. It is safer than the use of bacteriostatic. What else do we need to understand from these positions? From another side, the use of bacteriostatic antibiotics sometimes also has advantages. First advantage, just imagine a case when you need to use bactericidal antibiotics, but your patient has, for example, septical condition. Dozens and thousands of bacterial cells are present in patient's bloodstream. So what does it mean? It means that spontaneous lysis and simultaneous lysis of bacterial bodies will liberate endotoxins containing inside these bodies into human circulation. What can it lead to? obviously it can cause infectious toxic conditions, even infectious toxic shock. So in this case, the use of bactericidal antibiotic can be already more dangerous than the use of bacteriostatic. And in these cases, maybe it's more rational to administer bacteriostatic antibiotic. Next advantage of bacteriostatic antibiotic use. This advantage is related with the influence on intracellular flora. As we already discussed, bacteriostatic antibiotics can diffuse through cellular membranes. It means through human cellular membranes too. We need not to forget that some parasites, and later we will discuss these parasites, have an ability to live inside human cells. So-called intracellular parasites are Legionella, Mycoplasma, Ureaplasma, Chlamydia, etc., etc. So these parasites are called atypical because they have atypical intracellular, particularly, lifestyle. The use of bactericidal antibiotics, such as penicillins and another beta-lactams, cephalosporins, etc., is ineffective for them because they cannot diffuse through cellular membranes of human cells, and they cannot find and limit the reproduction of intracellular parasites. So intracellular parasites are trying to hide from us using our own cellular walls, cellular membranes as a shield. The use of bacteriostatic antibiotic gives us an efficacy in this case. That is why classical bacteriostatic antibiotics such as macrolides, yes, such as tetracyclines, yes, are drugs of choice in patients with atypical infections. So let's conclude, both bactericidal and bacteriostatic antibiotics are still present on pharmaceutical market. Both of them have their own clinical place. If we discuss the safety, usually the safety of bactericidal, classical bactericidal beta-lactam antibiotics is better. But if we speak about specific groups of patients, such as patients with atypical infections, is obviously preferable to use bacteriostatic antibiotics. Next classification of antibiotics and next feature of antibiotics is the presence or absence of acid resistance. Let's translate hydrochloric acid resistance. It means that drugs with this feature presence can be used orally. Unfortunately, first generations of antibiotics, I mean natural antibiotics, among penicillins, for example, cephalosporins, never had this acid resistance. It actually made their use possible only parenterally. More contemporary generations already received acid resistance, so we can use them both orally and parenterally. Of course, the possibility of oral use is very important, and especially important in childhood. Yes, just imagine a kid which actually has to take antibiotics. Obviously, it is better to take syrup or tablets, but not injections or infusions. Next parameter, features of pharmacokinetics. So different antibiotics have different specifics of pharmacokinetics, and sometimes these features of pharmacokinetics can become advantages. For example, duration of action. Obviously, if you need to receive prolonged action and a drug has this low prolonged action, you will prefer this drug. Ability to be accumulated in specific organ. This is also very important because sometimes it's very difficult to treat specific organs with specific circulation. For example, central nervous system, yes, due to the presence of barrier, blood barrier. Some drugs, pharmacokinetics, is used to choose the best drug in accordance to their excretion. For example, for the treatment of kidney, so they will gain good concentrations in kidney tissue and will have direct action in this locus of action. Criterion number 6 in the choice of antibacterial drugs is actually antibacterial drugs resistance. Yes, because unfortunately today in the era of spread antibiotics use, resistance becomes higher and higher, and this is a huge problem of contemporary medicine. I believe that after coronavirus pandemic, it will become even more serious problem because, of course, every time you administer antibiotic, especially broad spectrum antibiotics, you actually uh, make an impact on resistance in the future. Please do not forget, and please never use antibiotics without direct indications. Please never use broad spectrum antibiotics without significant indications for this broad spectrum antibiotics use. So let's discuss main antibacterial drugs classes, and let's try to understand main advantages and disadvantages of these classes. At first, of course, traditionally we start our conversation with beta-lactam antibiotics because they were first in the history, and today maybe this direction of treatment is the most popular in antibacterial world. So today main beta-lactams classes are penicillins, and as far as you know, penicillin was the very first antibiotic synthesized by Alexander Fleming. Yes, later we received cephalosporins, carbapenems, and monobactams. So all of these antibiotics, and even on this picture you can see all of them, they have a similar structure. The structure is so-called beta-lactam ring. This beta-lactam ring presence from one side gives them bactericidal action, so all of them are bactericidal, and this bactericidal action already describes some benefits for us, and the obvious benefit is the safety. We already discussed that, and the inability to diffuse through cell membrane. From another side, this similar structure makes some negative aspects possible, such as cross resistance. Yes, it means if a person has resistance for penicillins, the chance to receive resistance for cephalosporins is also very high, or for carbapenems even. From another side, this similar molecular structure makes gives us high possibility of crossing allergic reactions. And it is not very rare when patient having allergic reaction for penicillin has an allergic reaction also for cephalosporins. It is very important because it limits, from one side, limits the possibility of beta-lactams use. From another side, of course, a doctor should be very careful when he, during administration of beta-lactams, when previous beta-lactam classes already gave allergic reactions. Please never forget about crossing allergic reactions for these drugs. Penicillins. Penicillins are antibiotics synthesized in the nature by Penicillium strains. Today, the classification of penicillins contains actually 6 generations. This picture contains only 5, but I will give you 6th generation too. All of these generations are different in their features, their advantages, and their spectrum of action. So, colleagues, I should say that generations classifications are usually the best classifications because they allow very quickly and very simply to differentiate advantages and disadvantages of antibiotics. New generation invention means additional benefits from drugs. If a new drug class receives a new generation, it means that it is a new parameter of treatment, that it means usually breakthrough in medicine. For example, natural penicillins present on this picture, benzyl penicillin and salts of benzyl penicillins. Natural penicillins are gram-positive acting in their spectrum. Yes, so the use of these drugs is possible only in patients with gram-positive infections. Main disadvantages of natural penicillins are at first absence of acid stability. We already understood it means impossibility to use them orally. At second, the absence of beta-lactamase stability. So they are unstable for enzymes which are produced by bacteria against them. So that is why today penicillins are from first generation are almost never used. Another reason why these drugs are so unpopular today is the level of resistance. Today, the level of resistance for first generation of penicillins is already more than 30%, higher than 30%. The keyword is 30% because clinical pharmacologists assume if resistance is higher than 30%, this drug class or this generation of drug should not be administered because actually the treatment becomes a lottery and your patient participates in this lottery as a player. Will it be effective or not be effective? Yes, just imagine among 100 of patients, 30 patients don't respond to this treatment initially. Of course, it is not recommended. And today, the use of natural penicillins is limited. Second generation, so-called isoxazoline penicillins, oxacillin, cloxacillin, dicloxacillin, and another representatives are called acid stable. So let's translate. We can use them orally. And another name is beta-lactamase stable. Yes, so initially they were stable in presence of beta-lactamases, enzymes of bacteria which are trying to destroy these antibiotics. Unfortunately, today, bacteria can synthesize so-called extended spectrum beta-lactamases, and these extended spectrum beta-lactamases already can destroy second generation of penicillin. So today, this advantage is actually already absent. Next generation, aminopenicillins. Aminopenicillins are classical drugs and very popular drugs, such as amoxicillin and ampicillin. The spectrum of these drugs action is already wide, and we need to say this spectrum is even more gram-negative than gram-positive. Yes, and today these drugs are widely used in cases of infections which are related with gram-positive flora, such as respiratory infections, such as skin infections, such as upper respiratory tract infections and lower respiratory tract infections. The use of aminopenicillins actually depends on local resistance for them. And that is why, for example, ampicillin use today is rare because ampicillin resistance is already high, and in some regions it is close to 30%. So the barrier which makes this treatment ineffective. Of course, the resistance for amoxicillin is lower, and today in the most of cases, amoxicillin is a drug of choice. Another advantage of amoxicillin versus ampicillin is very good pharmacokinetics profile. Bioavailability is approximately 80%, while bioavailability of ampicillin is only 40–60%, which is also disadvantage. Yes, so just imagine you gave your patient 1 gram of ampicillin per dose, and only 400 milligram are absorbed into systemic circulation. Of course, this is maybe not rational, and that is why today amoxicillin almost replaces ampicillin from daily clinical practice. Next generations, carboxypenicillins and uridapenicillins, such as carbenicillin and ticarcillin for generation of 4, and azlapiperacillin and meslacillin for generation number 5. These drugs have a spectrum closer to gram-negative than gram-positive. And they were invented maybe to treat not gram-positive, but gram-negative infections. Generation number 6, which is not printed on this picture, is a generation of imidinopenicillins, such as amdinosilin, temacillin. Again, imidinopenicillins, amdinosilin and temacillin. If you don't know that, you can write that too. Imidinopenicillins together with carboxy and uridapenicillins are broad spectrum antibiotics, but main their advantage is influence on very specific flora. This flora is Pseudomonas aeruginosa. So Pseudomonas aeruginosa actually Look at this, generation 4 and higher. Pseudomonas aeruginosa is an infection which usually is persistent in intensive care units, in resuscitation departments, and this flora is usually related with huge level of mortality. So that is why the history of medicine tried to find new and new drug classes to treat and drug generations to treat this pseudomonal infection. So these generations among penicillins are generations number 4, 5, and 6. And if you suspect the presence of pseudomonal infection, especially in intensive care units, in severe clinical cases, of course, it's better to use generation 4 and higher. Next thing we need to know about the spectrum of penicillin's action. As we decided, the spectrum depends on generations. Yes, generations first and second are gram-positive. Generations 3 and higher are broad spectrum. But none of them, please pay attention, none of them have an action on so-called MRSA. MERS in abbreviation is translated as methicillin-resistant Staphylococcus aureus. Methicillin-resistant Staphylococcus aureus is a kind of Staphylococcus resistant for usual antibacterial drug classes. So it was found as a resistant for methicillin, but actually it is resistant for all of penicillins, almost all of cephalosporins, carbapenems, macrolides, aminoglycosides, fluoroquinolones, etc., etc. So this is a huge problem to treat MRSA infection. And actually the medicine invented special classes of drugs to treat MRSA infection. Yes, so let's make a conclusion. MRSA is methicillin-resistant Staphylococcus aureus, and look at this, none of generations are acting on them. MSSA means methicillin-sensitive Staphylococcus aureus, so it means usual Staphylococcus aureus. Yes, and it is usually affected by usual generations of penicillins. Next thing we need to know, actually, we need to remind each other that penicillins can be combined with so-called beta-lactamase inhibitors. Beta-lactamase inhibitors are molecules which are used to protect antibacterial drug from degradation, from destruction by beta-lactamases produced by bacteria. Yes, well-known molecules are 3: clavulanic acid, sulbactam, and tazobactam. So one of them is usually added into fixed combination with main drug. Fixed combination, it means inside one single pill. Yes, so drugs are combined with these beta-lactamase inhibitors, such as clavulanic acid, sulbactam, or tazobactam, to prevent the influence of beta-lactamases produced by bacteria. Well-known drug, and everybody knows this drug, is augmentin. Yes, this is combination of amoxicillin with clavulanic acid. So it is a combination of broad-spectrum penicillin from 3rd generation with clavulanic acid. Another name of this drug is amoxiclav. Yes, amoxicillin with clavulanic acid. Also very popular drugs are ampicillin with sulbactam. Trade name is Unacin. And piperacillin with tazobactam, international name is Zocin. Yes, so these drugs are combined into one fixed combination, and it allows to overcome resistance of bacterial strains. From one side, obviously, this is good. Yes, and maybe somebody can decide that every time you administer these drugs, for example, amoxicillin, you should use the combination with clavulanic acid. We need not to forget that these combinations have not only advantages, but disadvantages too. So main advantage, of course, is additional sensitivity in bacterial world, because the addition of beta-lactamase inhibitor allows us to improve efficacy. But from another side, we should not forget about the growth of resistance. So every time you use amoxicillin together with clavulanic acid, you give bacterial world an opportunity to be trained, to receive mutations, and actually to overcome these improved therapeutic forms of drugs action. Next disadvantage related with beta-lactamase inhibitors is their safety in pregnancy. You should know that the use of these combined forms in pregnancy is not recommended without specific indications, because all of these molecules have negative influence on the fetus. So amoxicillin itself, in comparison with amoxicillin clavulanate, is tolerated better in pregnancy. So the conclusion is very simple. You should avoid combined forms of these drugs in pregnancy, and you should administer them only in serious indications, because the addition of these molecules significantly reduces the safety. Next drug class, and also very important drug class used in antibacterial world, is a class of cephalosporins. Frankly speaking, cephalosporins are, if you wish, best friends of penicillins, and they have very similar molecular structure related with beta-lactam ring. So they have same advantages and disadvantages as penicillins, and main advantage is the safety. The presence of bactericidal action without influence on intracellular structures make the use of cephalosporins also safer. Of course, the safety of cephalosporins versus safety of penicillins is not better, and penicillins are better in safety, but cephalosporins are also widely used in medicine. Today, cephalosporins are actually divided into 5 generations. These generations are written on this picture, and let me comment some positions of these generations. So first generation actually are natural cephalosporins. Let's call 2 main of them, cefalexin and cefazolin. They are the most popular, and you can write them, cefalexin and cefazolin. First generation of cephalosporins have an action on gram-positive flora. And every next consequent generation makes the spectrum wider and wider and wider. Absolutely same as it was for penicillins. And actually this rule is even written on this picture. Yes, that first generation is predominantly active against gram-positives. Yes. Second generation drugs such as cefuroxime and cefaclor. Cefuroxime and cefaclor are also very popular. This spectrum is already more broad. It includes some representatives of gram-negative flora, but frankly speaking, this coverage is not clinically significant usually. So usually the second generation cephalosporins are also used to treat gram-positive infections. Generation number 3. Let's call main drugs from generation number 3. In contemporary guidelines, sometimes you can find that third generation is divided into third A and third B. Third A generation is cefotaxime and ceftriaxone. Cefotaxime and ceftriaxone. Third B generation is ceftazidime. So what is the difference between them? Actually, absolutely same difference as between generations 3 and 4 of penicillins. So generation third A doesn't have any action on Pseudomonas aeruginosa, while generation third B and later recent generations have an ability to kill Pseudomonas aeruginosa. So again, if your patient is severe patient, or your patient is in intensive care unit, you suspect the presence of Pseudomonas aeruginosa, your drug of choice should be the drug from third B, but not from third A generation. Yes, such as ceftazidime. Generation number 4, cefepime, cefquinone, and cefpirone in some countries. Generation number 4 are broad spectrum antibiotics, but it is approximately by 80% gram-negative, but not gram-positive. Generation number 4 today is assumed as a reservoir drug generation. Yes, so we use generation number 4 only in cases of resistance for previous generations, or when your patient already had the history of inefficacy of previous generations of cephalosporins. Today, this problem is complicated because cefepime today is included into the clinical guidelines for the treatment of pneumonia related with coronavirus infection and bacterial complications of this infection. It means that sensitivity for cefepime will be reduced in nearest years. Generation number 5. This generation of drugs was invented during last 15 years, ceftobiprole, ceftaroline, and ceftolozane. And this generation has specific action. This action is action on MRSA. So this is an exclusion from our rule when usual drug classes are ineffective against MRSA. So only 5th generation of cephalosporins has this action among usual drug classes. And actually, it was the aim of this drug classes, this drug generation invention. I believe that main position of cephalosporins use is the use of gram-positive infections for young generations of penicillins and cephalosporins. Yes, but if we need to act on gram-negatives, let's take a look. For me, 3rd generation and higher are recommended. Yes, if we need to act on MRSA, we should prefer drugs from 5th generation because previous generation don't have any action on this flora. So let's make a conclusion about both penicillins and cephalosporins. Both of these classes are usually safe in their use. Yes, they can cause allergic reactions, they can cause GIT disorders, but usually they are tolerated well. And criterion of this safety is the possibility of these drugs use in pregnancy. Please pay attention. Penicillins are allowed to be used in 1st trimester of pregnancy, cephalosporins starting with 2nd trimester of pregnancy. Feel the difference with classical bacteriostatic antibiotics, which are never recommended to be used in pregnancy. But also you need to know that the safety in pregnancy is a question of generation. So it's recommended to avoid latest generations of both penicillins and cephalosporins in pregnancy. For example, among penicillins, the drug of choice is a drug from 3rd generation. From cephalosporins are drugs from 1st and 2nd generation. So this is general rule. Latest generations of antibiotics were never tested in pregnancy or received negative results in pregnancy. And we should avoid their use without significant indications. Okay, colleagues, let's have a break. And after the break, we will discuss another classes of antibacterial drugs. Please have a break.